Hello, my name is Andrew Tai. I'm one of the staff physicians at the VA Ann Arbor Healthcare System, and today we'll be talking about a liver biopsy. I have no financial disclosures relating to the topics being discussed in this presentation. Just as an overview, today we'll be discussing the indications for liver biopsy, what we suggest as a pre-biopsy evaluation, the standard approaches to the liver biopsy, the common complications of liver biopsy, and then we'll discuss the technique that we use most often, which is the transthoracic approach. Common indications for a non-focal liver biopsy, that is a biopsy not of a focal liver lesion but a random biopsy of the liver, are principally a diagnostic. So for example, if one suspects autoimmune liver disease such as autoimmune hepatitis or primary biliary cirrhosis. Another situation is when there is diagnostic uncertainty as to the cause of elevated liver biochemistries, or sometimes in distinguishing two chronic liver diseases such as NAFLD versus autoimmune hepatitis. It can also be used for obtaining tissue for quantitative iron or copper measurement. It is often used after a liver transplant to evaluate possible causes of abnormal liver biochemistries. And on occasion, when there's a suspected systemic process such as sarcoidosis or amyloidosis or some other diffuse process that may involve the liver. Liver biopsy can also be used in assessing disease severity, specifically liver fibrosis in a variety of chronic liver diseases, and also in disease monitoring such as in autoimmune hepatitis. For pre-biopsy testing, we suggest at the minimum CBC for platelet count and coag such as INR and PTT. I also like to review imaging reports whenever they're available. For example, is there a large focal lesion in the right lobe, such as a hemangioma? Also to exclude biliary dilation, which can increase your risk of bile leak after a biopsy, or otherwise unusual anatomy that you might not otherwise be aware of. In terms of medication management, there is limited evidence for these recommendations, and we would suggest that specific drugs should be considered on a case-by-case basis. That being said, therapeutic anticoagulation such as warfarin should be discontinued at least 5 days prior. Whether or not the patient needs to be bridged with low molecular weight heparin, for example, is also done on a case-by-case basis. We would suggest that you consider holding antiplatelet agents for at least 7 to 10 days prior to the procedure unless there's a strong indication to continue, such as the patient who has recently received a drug-eluting stent. Just to review liver biopsy approaches, the common approach that we use as hepatologists is the transthoracic percutaneous approach that we'll be demonstrating later on in this video. Other approaches include the subcostal percutaneous approach, typically done by radiologists, and this typically requires real-time image guidance. An alternative approach is the transvenous or transjugular approach, where a catheter is introduced usually through the internal jugular vein down to the hepatic veins, and a biopsy can be done through a transvenous approach. This can be an option, for example, if there is significant ascites, if there is a known or suspected coagulopathy or other bleeding diathesis, or if hepatic venous pressure gradient measurement is also needed. A final approach is the surgical or laparoscopic approach. This is sometimes done when a patient is otherwise having another surgical procedure and liver disease is suspected at the time. The common complications of liver biopsy include pain. This is common, but typically should be managed by analgesics such as acetaminophen or Vicodin. Severe pain should raise concern for a complication such as bleeding. Bleeding is not uncommon, but typically is intra or perihepatic and is not serious, and is usually self-limited. Severe bleeding is usually intraperitoneal. Miscellaneous complications include the risk of a bile leak, pneumo or hemothorax, hemobilia, infection, or injury to the gallbladder. Contraindications to a percutaneous liver biopsy include an uncooperative patient, the inability to identify a suitable biopsy site. Those may be caused by a small or cirrhotic liver in the morbidly obese patient, or if lung, bowel, or other structure is no way. In those cases, image-guided biopsy might be more suitable. Significant ascites is a contraindication to a percutaneous liver biopsy. Biliary dilation on imaging, chest or abdominal wall infection over the planned biopsy site, or coagulopathy or some other uncorrectable disorder of hemostasis. We will now review the transthoracic liver biopsy technique, and we will discuss patient positioning, identification of the biopsy site by percussion and ultrasound marking where it's available, preparing the field, infiltrating the area of local anesthetic, how to identify the intraperitoneal space with a suction needle, and then actually obtaining the biopsy specimen. So first, we'd like to just review the contents of your liver biopsy cart and other things that you may want to have with you. You will want sterile gloves. This is a clean procedure, but not necessarily a sterile procedure. You don't have to wear sterile gowns or a hat or things like that, but you should have sterile gloves. 4x4s at hand, skin prep, and a specimen bottle for formalin. In specialized cases such as needing to get fungal cultures, you may need to have additional containers for those kinds of specimens. A surgical marking pen can also be helpful. But the contents of a liver biopsy tray should include a drape over the field, usually a fenestrated drape and sometimes a non-fenestrated drape. Sometimes additional skin prep is in the tray. You will also need lidocaine for local anesthesia. And then finally, usually a vial of sterile saline, which we will use for obtaining the actual biopsy, and we'll discuss that in a minute. There should also be a syringe for local anesthesia, and then finally the actual suction needle shown here. And we will discuss that also in another minute. Okay. You will then at this point draw saline into your suction needle. And you also at this point want to make sure that the needle is tight on the syringe to avoid any air or vacuum leaks that might cause problems for the procedure. So for patient positioning, it's important that both you and the patient are comfortable. So we usually like to have our patient come over so that his or her side is right up against the edge of the stretcher. There we go. And then the right arm can usually be placed above the head. And this exposes the intercostal spaces. And this is optional, but some people like to have the legs a little bit over so the patient is somewhat curved. And this has the effect of opening up the intercostal spaces. And at this point, we're going to pull up his shirt here, scrub top. And can you just give us a little bit of room here? Okay. So even if you have ultrasound available at institution, we would suggest that you palpate and percuss the liver first to localize your site. And what you'd like to do ideally is to percuss out this liver span. In the intercostal spaces. Now, pretty typically, where you'll be approaching is 2 or 3 intercostal spaces above the inferior costal margin. You generally want to approach in the mid-axillary line. In fact, we'll get our marking pen at this point. One common pitfall is to approach too far anteriorly, which puts the needle in the path of the gallbladder, or too far posteriorly, which puts the needle into the path of the kidney. So the mid-axillary line. And in general, the needle is directed towards the xiphoid process, parallel to the plane of the floor. So if you have ultrasound available, what you'd like to do is to basically look at your chosen area that you determine through percussion. And I like to direct the ultrasound probe so it's pointing towards the xiphoid process because that will be your approach for the biopsy. Now, at this point, it's important to look at the liver at end expiration. That will have the effect of making the lungs physically smaller, the liver will rise up in the chest, and there will be a lower risk of causing a pneumothorax. So I usually ask the patient at this point to take a deep breath in and a deep breath out and hold it right there. And as you can see, there's significant respiratory motion with breathing. And again, deep breath in and deep breath out and hold it. And you'd like to basically ideally confirm your view at end expiration. Okay. And that's a good view of the liver. You see these small venules and blood vessels in the liver. And we're out of the way of the gallbladder. So this is a reasonable place to go. And you can breathe normally now. So once you've identified a biopsy site on percussion and ultrasound, you can then mark the site again in the mid-axillary line. We'll then sterilize the area using a standard chlorhexidine or iodine skin prep. And at this point, you should also then put on your sterile gloves And if your fenestrated drape has adhesive, we can then apply it. If not, you can use tape. And now our site is draped. Personally, I like to then also I like to reconfirm where the xiphoid process is, because that will be the direction my needle is tracking. And for what I would suggest can be helpful is simply placing some kind of visual marker, such as a 4x4 there, just so that you can see when your hands on the needle where the xiphoid process is. You can use a clamp, you can mark it with a marker, or I just usually just leave a 4x4 right there so I can see where my needle is pointing. Now at this point you will then infiltrate the area, the skin, with lidocaine. This is just a superficial skin wheel. You don't have to place too much lidocaine there, otherwise that might distort your anatomy somewhat. So just a small skin wheel. So after performing the initial skin wheel to anesthetize the skin, you will then want to anesthetize the intercostal tissues. Your needle should follow the path that your biopsy needle will take, which is namely pointed towards the xiphoid process, parallel to the floor. At this point, I also like to go over the patient again, the breathing, namely taking a deep breath in and a deep breath out. Deep breath in and a deep breath out, and hold it. And during this breath hold, you can also then anesthetize intercostal muscles and practice at this stage. And you can breathe normally. And you will want to also avoid not injecting so much anesthetic that you distort the intercostal tissues. Okay. It is also important at this stage to make sure the needle follows over the rib, so as to minimize the possibility of nicking the blood vessels, which usually are underneath the ribs. The next step after anesthetizing the intercostal tissues is to perform a skin nick. This is a simple stab with a scalpel blade, which should be in your kit. And it should not be a large incision. A simple stab to about half the depth of the blade should be more than sufficient at this point. For the actual liver biopsy, notice that the needle is graduated in centimeters. It's important to have your free hand not only stabilizing the needle, but acting as a hard stop, so that the needle can't inadvertently go beyond where your planned biopsy extent is. Again, we are entering the tissues parallel to the bed, pointed to the xiphoid process. As you pass through the intercostal tissues, I like to have a little bit of negative pressure just to confirm you aren't entering a blood vessel by mistake. However, as you feel a pop and you enter the intraperitoneal cavity, at this point you want to inject a little saline to flush the needle of any tissue that's been trapped along the way. Also, I think to help confirm that you're in the intraperitoneal space, because the saline should flush fairly freely at that point. At that point, have the patient take a deep breath in and deep breath out. Deep breath out. You want to apply forceful negative pressure on the plunger. At that point, in one smooth motion, you want to advance the needle and take it out. And that whole biopsy process should take about 1 second. At that point, I just want to reemphasize that as you obtain the biopsy, there should be negative pressure on the plunger as you enter the liver. The suction is what actually obtains your liver biopsy. And this should be a smooth motion in and out. So at this point, hopefully your assistant will have an open formalin bottle. And at this point, you simply will expel the liver core into the bottle by pushing on the plunger. You should then look at your core biopsy. Usually, you'd like to have at minimum a 15 to 20 millimeter core to be assured that you have a adequate sample for pathology. Routine post-biopsy monitoring at our institution, we place a sterile 4x4 over the biopsy site and ask the patient to lie on his or her right side. The patient should be kept NPO. We monitor the clinical condition and vital signs for 2 hours. After that, we allow the patient to walk within the hospital for 2 hours prior to the final clinical check and discharge.